Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Aloha Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Yep, and we are the only radio show in the state of Hawaii that does this, and it's a real blessing to be able to give you information so that you can deal with this situation of veins. And this is not just a pretty show where you got those little spider veins on your legs and you want to get them fixed. Although of course Doc's happy to do that; it's part of the services they provide. But this is vein disease, and today we're going to go back and go into our mailbag. In which we get a whole bunch. You can drop us a line to me, the Mike Buck Show at gmail.com. You can go to the website of Vein Clinics of Hawaii, veinclinicsofhawaii.com, and read in and ask a question and get it answered. And sometimes we compile that because every now and again, Doc, we've discussed over the years that, when somebody has a question, they are just the tip of the iceberg. There's 100 more people also listening that have the same question. They just didn't know it was their turn to call.
Yeah, absolutely. Yeah.
And so that is different. And before we actually start about vein disease, I got this one question. And this came from a guy on a neighbor island who says that and I guess he doesn't know about vein clinics on the Big Island because he's from the Big Island. Yeah. But what he's worried about is how to maintain. His question is, how do you maintain a healthy vascular system? Do you have any tips?
Yeah. Well, that's a loaded question.
I should say. Yeah,
there's a lot going on there because the circulation is a lot of different things, but we talk about veins a lot, but there's arteries in their veins. Arteries carry blood to the entire body, and veins bring the blood back from the body to the heart. But when we talk about the circulatory system, I mean the heart is a part of that too. Taking those things individually, it involves, so many things, not only, diet and activity and exercise and, doing the things that you should be doing, by advice from your physician.
Sure.
And just kind of covering all bases, but activity is good for everything.
And thereby, and listen, we've done this before in different pieces, but the question also goes on to talking about exercise and diet. Can you cure vein disease by any of these things? And you've been really clear about that. At the moment there really is no cure,
right?
But there is treatment.
Yes.
And if you differentiate between that and the thing, so one would say that, if you're talking about a circulatory system, you're talking about blood. And what about things like diabetes or high or high blood pressure?
Right.
Or I don't know, maybe that some people have low blood pressure.
Yeah, and that's why I say, I mean, it's so very important for everything that, if you are diabetic, then you need to be working with your primary care doctor in controlling your diabetes as much as you possibly can. If you are overweight, then you need to be working with your primary care or whomever and, trying to get yourself down to, a more normal...
A fighting weight.
Yeah, fighting weight. And that could be said for everything, diabetes, high blood pressure, weight, et cetera, cholesterol, all those things. But with respect to, the question of arteries versus veins, I mean, one of the differences between those two things is that, what can we do to impact the course of arterial disease? Mm-hmm. What can we do to impact the course of venous disease? And, unfortunately with venous disease, there's not a lot of things that we can do.
I was going to ask you, it's not as though you can say this came exactly from here.
Right.
And a lot of it came from, God bless mom and dad, it came from your parents.
Yeah.
And we've learned that over time. But there's another thing, and I think that in this day and age, and I know that there are people listening right now to our program that are listening online. And a lot of people go online to do this thing, period. And it's my concern, and this question always comes up, what symptoms are related to a possible vascular problem? That's a 4-hour answer coming up on that one, right? I mean, but seriously, I think that, if you click on something and you say, "Oh, eureka, I found it." It says drink sarsaparilla. Mm-hmm. I'm drinking sarsaparilla and I'm not, and I'm down the road. Yeah. Let's talk about that. You talk about what comes first, the symptoms or the treatment.
Yeah.
You got to be able to go in and articulate your symptoms, but in some, let's say you have somebody, I've always wanted to ask you this. Let's say they have somebody that is, not able to speak or not able to see, and some of the other things that you've dealt with when people have, venous issues that have other complications. Isn't it sort of interesting that the way they get questions answered and the way they study things? They're not going to go online and look at something because they can't see. Right. But they sure are inquisitive.
Oh, sure.
So let's talk about what symptoms can somebody have right now that would give them an idea. I might have vein disease.
Yeah. Well, probably the three most common symptoms are achiness, heaviness, and fatigue. Those are probably the three symptoms that are most specific to venous insufficiency. And consequently, those are the three most common symptoms that are relieved most reliably when we treat people. But so many people come in and say, "Yeah, gee, my legs are tired. They just I don't have the energy that I used to. I get tired quicker than I used to." And so after we fix them, after we repair their venous problems, they say, "Oh, gee, my legs, they just feel light now, and I've got so much energy." So
and that's me. Not only am I, the host of the show with Dr. Julep every week, but I'm a patient. And with me, as we age in place, and we are all doing that, what can you do, again, that you couldn't do for a while, is the proof's in the pudding. And I have that now. And I think I attribute some of that not just to my 2 hours of elevating my legs, which I don't do anymore because I wear compression socks during the day. Yeah. So now when I lay down, I go to sleep. But I think that one of the number one benefits to me, and I'll ask you if this is a common benefit, is I sleep better. And it's because I don't have leg cramps. I don't have tiredness. I don't have throbbing. I don't have tingling. I don't have itching. I don't have the stuff that I used to have.
Right. Well, you just went through a very good list of symptoms. But I was going to say, the three symptoms that I just mentioned are the most common. But the next ones up are swelling, cramping, and restless leg. Now, are there other things that cause those things other than venous disease? Yeah, there are. But swelling, muscle cramping, and restless leg syndrome are also very, commonly caused by venous insufficiency. And when people go to bed, that's what happens to them. Yeah. They get muscle cramping, especially like in the middle of the night or early in the morning. And when they go to bed, they have this situation where they have restless leg, which basically what that means is that when you go to bed, I think we talk about it being related to bed because people go to bed, they all of a sudden they're still, and they don't really they are focused on their legs because now they're really feeling the symptoms, and when they're up and around, they're active, they're moving their legs, but they get into bed and they just can't get comfortable. They have to move their legs a lot until they do get comfortable.
What about this? As their doctor, are you amazed or sometimes surprised at the amount of discomfort or pain or symptoms that somebody can go through before they see a doctor? I mean, look at how many people. Like I said, if I could only kick myself, I would, and that's how I am. And I know that 99% of the patients that go through Vein Clinics of Hawaii also get that. But there's no reason why you can't say, okay, I'm sorry I missed the boat for the last 20 years, but what can you do for me now?
Yeah. Well, better late than never. Yeah. But we do hear that all the time. People say, gee, I wish I would have done this years ago. Yeah, the thing about symptoms of venous insufficiency, they come on very slowly. I can't fault most people because as humans we have a great adaptability. I mean, it's incredible what people can adapt to, and so the symptoms of venous insufficiency come on over for most people very slowly and over such a long period of time that you just kind of get used to it, and also so many people feel like it's just a natural part of aging, leg pain and tiredness and muscle cramp, all those things. They feel like, well, if I had $1 for every time somebody said, "Oh, I'm getting old, so that's why I have that."
I hear that all the time. You hear that all the time.
Yeah, and
that's not true.
That's not the case. No, I mean, there's a lot of things that can be fixed, and it happens as we get older, but it's happening because the process is there longer. It's not necessarily that we're old. It's just that the process started a long time ago, and as we age, that's just more and more years that process is going on and making things worse and more symptomatic for you.
Yeah, and we'll give you a long list of those whenever you want. And remember, it's like, even though you can't reach us during the program because this is pre-recorded, you can go to the mailbox. You can go to veinclinicsofhawaii.com and send them an email. One of the things that this happens a lot, and it says, we've often heard you talk about something called sclerotherapy as a treatment for my veins. What is sclerotherapy, and more importantly to me, what are some of the side effects that it might have, if any?
That's a good question. We use sclerotherapy in a number of different ways, we really use sclerotherapy to treat in one way or another pretty much all of the veins that we treat. No matter what size. Now, we use sclerotherapy extensively when we're treating spider veins. The way that we treat spider veins is to do, we inject medication into the vein, and that's called injection sclerotherapy. I guess, as a point of, definition, sclerotherapy means that we're injecting a medication into a vein that's going to basically sclerose that vein, and that means that it's causing inflammation inside the vein, and that inflammation then makes the opposing walls of the vein stick together.
Okay, so this sounds to me like see ya. I mean, that's the end of that vein.
Yeah, right.
Or that part of it anyway.
Yeah,
for sure, yeah.
And if we're treating spider veins, then if the vein collapses, then it becomes less visible. So we use it extensively in spider vein treatment, purely a cosmetic kind of procedure. And there's a couple of different medications that we might use related to that.
Back in the day, decades ago. And by the way, Dr. Julev is amazed. It always amazed me because he was a heart surgeon. And what turned him into this is he understood that what goes into the heart surgery that he's doing is because of all of these veins and arteries that get jammed up. And if you fix them, you're fixing people's hearts. And I think that being said, that, if you could explain back in the day how they treated spider veins, even that was invasive, wasn't it? Didn't they actually cut them out?
Well, no, we never really cut spider veins out because spider veins. The thing with spider veins is that they are in the level of the skin. All the other various sizes of veins that we treat are below the skin. Was
there before sclerotherapy to me? Of course, it's a new word for me, but I guess it's been around for a while. What did they do? I mean, what was the common procedure for spider veins?
Well, it's always been injection sclerotherapy. Okay. It's just that the medications that we've used for sclerotherapy have improved. Back in the day, 20 years ago, people were using primarily saline, what was called hypertonic saline.
Okay.
And the hypertonic...
Did that have side effects?
The main side effect was it was a fair bit more uncomfortable than the medications that we have today. It burned quite a bit more. And also the results in general were probably not as good as what we get with the medications that we use right now. But as far as the side effects, I think, or the risks, or maybe the drawbacks, or whatever, to sclerotherapy for spider veins. I think the main one is just non-response.
Okay,
I think that most people, unfortunately, they come in and they want their spider veins gone.
Right. And by the way, it's equal. Back in the day, it wasn't anywhere near as many men, but because if you're out playing tennis or jogging or surfing or swimming in Hawaii or just doing yard work. And then some places on the mainland, you're covered up like with mucklucks and long pants and sleeves. You don't, who cares?
Right.
But once somebody, especially their kids or their grandkids, you notice that? Hey, Papa, what's that big thing in your leg?
Yeah, exactly.
So that means that, so the side effects made the profession look for something that had fewer of them?
Yeah, well,
in other words, the liquid now? What is it?
The medication that we use nowadays, there's two main ones. There's something called polydocanol, and the other one is called cetridecol. So, they're both sclerosant. They both create inflammation inside the vein. They're not quite. The medication doesn't sting quite as much as the hypertonic saline. They tend to be a little more effective, but still, it's never 100% when we do injection sclerotherapy for spider veins.
Okay, but interesting though. One more fast one on that one, and this piggybacks on to what our listener wanted to know anyway, and that is, if that's the case, if it is less painful. Does it also matter who administers it? And I'm guessing absolutely, because if you get a newbie and you've been around for a long time, you know that they may not need an ounce of something when a half an ounce would do. So don't you sort of by eyeball or in your case by your brain say that needs this.
Yeah,
and no more, no less. That's going to fix this.
Yeah, you wouldn't think that injecting some medication into a few little spider veins, there's a huge expertise, but there's a definite learning curve, and it's even though it seems like a fairly simple procedure, it's like anything else. If you need to go to somebody who has done a lot of it, and chances are you're going to get the best result from that person. But the other potential risk from spider vein injection is something that we call hyperpigmentation. And unfortunately, when sometimes not it's a minimal number of people, and when it does happen to somebody, it's not like it happens everywhere, but maybe in one or two places. But sometimes we inject the spider vein goes away, but there's a little bit of pigmentation that occurs, and typically that goes away with time. But so we use sclerotherapy on spider veins, but we use sclerotherapy on larger veins too. And the next kind of vein up from spider veins is something that we call either reticular or tributary, secondary branches of the main venous system, and sometimes we use sclerotherapy on those to get them closed if they are refluxing and creating problems. When we do sclerotherapy on those bigger veins that are a little deeper, typically we're utilizing the ultrasound machine.
Gotcha. Yeah.
So we do the procedure is called ultrasound guided sclerotherapy. But then we also sometimes use a chemical sclerosant when we're treating even the bigger veins, even the main what we call axial saphenous veins. There are other procedures that are a little more reliable, but we use sclerotherapy on those veins too. So
and gang, I wish that this was like next week, because I'm doing this in a couple of days. Yeah. I'm going in for that treatment, and it is really based on it was a year, just under a year that I hadn't had a ultrasound.
Right.
And I made it my promise to myself, and I know a lot of your patients do, every 6 months or every year, just get a follow up to see where you are next time. And we found out that I'm going to have sclerotherapy treatment. And there's a big differentiation, isn't there, between something that is strictly cosmetic and something that is a vein that you are treating because it has this condition, because it is
for a medical reason. Absolutely. Yeah. And reticular and tributary type veins, even though those are also small, we look at smallish. They're not as small as a spider vein for sure, but we look at that as part of the medical problem of venous insufficiency, and it's important to maintain control and to minimize the number of those type of veins that are problematic at any one time. And yeah, I think, periodic surveillance ultrasounds for people who have been treated, very important. That's one of the things that we do much better now than we did years ago. Years ago when we were doing surgical vein stripping in the hospital, unfortunately we tended to, evaluate those people, see them, operate on them, and then it was kind of like, okay, see you later, you're done with your surgery. Well, that's not the best way to treat vein disease.
Yeah, and I'm really glad that I'm doing this again because I know what it is and I know what to expect. And the difference is, and this is what I wanted to ask, that you can use that on even big veins, from what I understand. And so that then becomes, it's one of the tools in the arsenal. But sometimes, I don't know, is the risk bigger than others for side effects? Because I haven't had any. So if anybody, a lot of people have asked me, well, what happened afterwards? Nothing. You take the bandage off the next day, maybe a little discoloration, but you told me just be patient, and I was a patient because it goes away. You just have to it's a leap of faith. Trust.
Right. Yeah, you do have to be patient in some situations, but with respect to risks, this sclerotherapy is something that we. One of the things that we're concerned about with sclerotherapy, one of the things that we're concerned about with all vein disease is DVT as a risk. So, when we're fooling around with the venous system and, occasionally people may develop a DVT blood clot.
Right there.
From the procedure. And depending on the medication, depending on the preparation, depending on the location and the anatomy and all that sort of stuff, can sclerotherapy lead to something like that? Yeah, it can. But again, it happens very, very rarely, and we take a lot of precautions to make sure that it doesn't happen by doing specific kind of things when we're doing those procedures.
And that's what this guy was talking about, the micro needles that you use. And my question is, and although he didn't articulate it, I would guess that's what he's thinking is it sounds like something's happening very topical right there. I mean, and you don't want it to go anywhere else. I mean, if you inject something into my vein, it isn't likely to go into my heart or my brain. I mean, if that vein is still working a little bit, can some of that stuff go up there? And if so, does it damage? And the apparent answer is no.
The answer, interestingly enough, the answer is some of that medication can go other places. And one of the things that can happen is that some of the medication, especially if we mix it with air, some of the medication that we use, we have found that it is more effective if we mix it with air. So we make a foam out of that. Now that has been studied. So
I think I had that once, to tell the truth.
Well, you did have that. You did have that. And so that has been studied. The question of, is some of this foam making it up to other parts of the body, either through the heart or into the brain? And the answer to that is yes. It does. Sometimes we see, if we're looking for it with an ultrasound machine or something like that, we can see that those air particles in other parts of the body. By and large, it's very, very rarely does it become symptomatic, and virtually never. If somebody does have a symptom that might be related to a little bit of air getting into the cerebral circulation, invariably it's a symptom that goes away very quickly.
Okay, the other thing is that a lot of people don't know is the non-invasiveness of the sclerotherapy is its biggest value. And typically speaking, not about side effects, but how are you when you've had it done? How much can you do at one time, and what happens after that? I mean, does the guy just go home?
Yeah, the patient goes home, just like all the other things that we do. We wrap up their leg and they go on their way. But is there, because of these other issues, is there a limit of the amount of medication that we can give any one person at any one time? Yes.
Yeah, and that's why I was asking that, because I remember having a lot of work done a while ago, and we did one on Friday and the next one the following Friday.
Right. Right.
Because your schedule and my schedule, that's how it worked. But it's not And that's another thing. And I know patients get real confused about this, and I've got that in another question. Is how are the fees charged? Is it number of veins, is it time? What is it?
Mm-hmm.
And I do know that a lot of people don't know that, that you do as much as you can in the session to sort of amortize the cost of any one part of that. You know what I'm getting at?
Well, for spider veins, spider veins is the only thing that isn't covered by insurance.
Right.
And we've got sort of our set, costs for those things. But, typically what I like to do is, I spend time. I spend a certain amount of time.
Right.
If I'm doing the procedure, I'll spend 45 minutes is what I do.
Okay, but wait a minute. When it comes to time,
yeah,
I want you. I don't want the new guy. Okay, I want the guy that's done. In other words, I talked to another very good surgeon friend of mine not too long ago, whose specialty was bariatric surgery.
Yeah,
and he could do 2 or 3 a day.
Mm-hmm.
And sometimes that's how his practice was. And there's some that would struggle with just doing one because of the nature of it. So I would imagine, because you've done this just 10 zillion times, that if it's about time, the main thing a client wants or a patient wants, I want value. I'm going to pay. It's an elective procedure.
Right.
So I want to know how much you can do. And so at some point in time, you say, okay, we're going to do as much as we can. And then you don't want to be Superman here.
Right.
Because, so does that indicate that it might hurt a little bit later on?
Well, it
hasn't me.
No, it does. It doesn't hurt afterward. Especially if we're talking about spider veins.
Yeah, exactly.
Then I think the main discomfort, and it's minor really, but the main discomfort is during the procedure. But we use a tiny needle.
Yeah.
I mean, it's the smallest needle you can get to inject the vein. But it's not necessarily the needle as much as the medication going into the vein that might create a little stinging.
Sure.
And a lot of it's interesting. When we're injecting spider veins, a lot depends on like the location of the leg. Some areas tend to be, some areas of the leg, the patient doesn't feel anything.
Yeah, that by the way, I don't have to verify the doc because he's telling you the truth. I promise. But I had that happen one time. I had this big nervous thing going on, and then it's okay. You're out of here. What do you mean? And there is a difference, and I know that some people. You could get a big lumberjack that's just this mean old macho guy, and you get this little skinny little lady, and she can take pain more than the big guy does. Yeah. And I know that you run into that, right? It's not. It's that if you are a person that is pain easily, then you're going to have some pain. But it really is when you say little, and maybe you can go further on it a little bit when you talked about the ultrasound guided sclerotherapy, and this dinky little needle. That's got to be the biggest invention of all. How do they get that needle so little, and how does that stuff get through it if it's so little?
Yeah. Well, now the smallest needle we reserve for spider veins because we really need it. Now, when we do what's called ultrasound guided sclerotherapy, which is the procedure you're going to have, we use a little bigger needle, but it's still pretty small. It's a very thin needle, but it's longer because we have to get deeper into those secondary branches. Even with ultrasound guided sclerotherapy, people can feel a little stinging that happens kind of underneath the level of the skin. So it's not created by the needle, but it's created by the medication going in. And during that procedure, I think I have found more than anything that the stinginess is sort of related to the amount of medication that we're able to get into, a vein or a vein complex. Yeah,
there's another thing that came up, and one of the things that somebody wanted to know back when we were talking about sclerotherapy is that the recovery period. I mean, and I know that's a great question. A lot of people want to know about that. And I'm going to tell you folks that, I'm one of these big guys, but I'm not like a friend of pain. And I expected that I was going to take a couple of days off, and I didn't. And I think that that's what you hear more and more often these days. That, I want to do it. I want to do as much as I can, more bang for my buck, but I also want to go to work the next day. So you got to guide me as how much of this can I take? Yeah. Because it feels pretty good so far. You want some more? Yeah, give me some more.
After cosmetic sclerotherapy for spider veins, basically anybody could go back to work for sure. And most of what we do, I mean, the main restrictions are heavy lifting, and but otherwise, I tell people they can pretty much do whatever they feel like. So sclerotherapy is a big part of what we do, and we utilize it in many different situations. But getting back to spider veins, like I said, the way I do it is I spend 45 minutes. Now, I've kind of come up with that 45-minute time period because most people, when we do our sclerotherapy, we're doing sclerotherapy on both legs, front and back, the whole thing. And for most people, in 45 minutes, I can get to pretty much all of their main problems. Now, are there some people that I know I'm not going to get to all of it in 45 minutes? Absolutely. And so we might identify that at the outset. And
so gang, if you heard me, it's too bad because you can't just follow me like Johnny Appleseed. I'm going to have this procedure done in a couple of days, and I know that the longer you wait in between tune-ups, the more work there's got to be done. So wouldn't you rather have an annual checkup? Because I don't care about spider veins for vanity's sake. I mean, maybe I do a little bit, but I don't really. But what I do know is that every time I come in, that if it's at all possible, you get one of those to go away. But the biggest question that I've been asked, and I had it myself, and you made me happy with it, you have to be patient because tell us why. Sometimes you get this motley colored and yellow and stuff going on. And you think, man, I look better when I had the dang veins. What happens? Why does it take that? What happens in there?
Well,
when it starts going away.
Again, as it relates to spider veins, the way that the medication works is by creating inflammation inside that vein, and the inflammation then causes the vein to collapse, and then it becomes less visible. So whenever we create inflammation, especially within the skin, you're going to see that at the level of the skin. So we warn everybody that after we do spider veins on them, we say it is going to look worse before it starts to look better.
And you know what? I'm telling you, I had one that Dr. Julep did for me. It was I can see why they call them spider veins because it looked like a spider's web. Yeah. And it was very big. It was bigger than a softball. And it was on my upper left thigh for probably 20 or 25 years. Yeah. Or longer. I don't even know. Yeah. But it looked so bad. And Dr. Julep was on one of his Neighbor Island offices the day that I really felt bad. But you know what? I called up and I said, I think I should come see the doc. What seems to be the problem? And the girl, and I told her, I said, well, my leg's like really a weird color. She says, forget about it. Don't come in. You're going to be okay. It is, though, to me, I'm fascinated by that because there were some risk takers at the very beginning, right? I'm talking patients as well as doctors.
Yeah, sure. Oh, yeah, at the very beginning. Yeah, definitely, like everything in medicine. But
what's the follow-up? Let's say I'm coming in on Monday, and I'm going to have some of that work done, some sclerotherapy, and then you follow it up to make sure what? Is there some bleeding? What happens afterwards?
Well, you should have very, very little bleeding. I mean, it's like, again, a small needle going through the skin. So there's not, you might have a little bit of bleeding at a needle site that goes away quickly. So it's not like there's anything that's going to happen after you leave the office.
You don't have to go home and throw away your sheets or any of that stuff.
But we want, even though it's not one of the more major things we do, we still want you wearing your stockings for about a week, and beyond, obviously. But for that procedure, we tell people wear thigh-high stockings for a week. There's a tiny bit of discomfort, but usually that immediate stingy discomfort kind of feeling goes away as soon as you get up and start walking.
Well, look, gang, you got to look at it the way I did, and it's not rationalization or try to trivialize anything, but it took a long time to get them. And so to expect him to go away the first day you meet Dr. Jewell is not going to happen.
Yeah.
But it will.
Mm-hmm.
And that's the part. I think that's when you and the practice and everybody else at Vein Clinics of Hawaii gets all fired up because people are so excited.
Mm-hmm.
Mom, remember that thing that you saw on my leg? Look, it's gone.
Right. We can, with respect to spider veins, we can make most people's legs look quite a bit better. But yeah, you kind of hit the nail on the head before when you said patient. Patients do have to be patient, because it doesn't go away right away. Like I mentioned, when we inject veins, they look worse for a while before they look better. Well, they're real red and inflamed, and you might have a little bit of bruising and that kind of stuff. But that kind of resolves after 5, 6, 7 days, and then after that resolves, then things do start to look better. Now, the other thing about spider veins and people having patience is that the improvement that we see in how the spider veins react or how they look, the improvement goes on for about 3 months. Mm-hmm. Now that's a good thing because improvement is going on for 3 months. Yeah. It's not so good because it takes 3 months to reach that full improvement. It's not like a steep hill up. Within a couple of days you're seeing all the improvement that you're going to have.
However, what I think is interesting to that. And by the way, I didn't mean for any, to turn this into strictly a spider vein show. But since most of us that have vein issues have spider veins, I think more importantly that when you talk about that gap and that time to get things repaired, it seems to me that the other benefits of the more medical surgery we do, those results are kind of right away.
They are.
You're not waiting 3 or 4 months to be able to have that leg feel better. It feels better like today.
Right.
That's amazing.
Yeah. Concerning the other more medically related things that we do, when somebody has bad reflux in for instance, a saphenous vein, that is very significant in creating symptoms and other problems. We close that vein, and what we're doing is we're getting rid of the abnormal flow. Right? So before we do the procedure, the blood's going in the wrong direction. We close that vein. That stops that abnormal flow, but it then forces your body to reroute that blood that would otherwise be going in the wrong direction to normal vein. And it's amazing how quickly people do feel better. I mean, it can be overnight. Sometimes we have people say, "Gee, as soon as I had that procedure, I could feel something happening, and my leg was feeling better as I was leaving the office."
I want to tell you something. As silly as that may seem, it is and was true for me, and I think that's because if you have a headache and you take an aspirin and the headache goes away, the aspirin it worked. This is a similar thing. It's not a pill. It's something that you had done. But what I'm very interested about, as you said this before, is somehow that blood that used to go up that vein that's no longer, there, it goes somewhere else. But isn't it a miracle of nature of our anatomy that happens? Because this blood thought it was going over there, and there's no door there anymore. I got to go somewhere else. Yeah. But that happens instantaneously, doesn't it?
It does. Yeah, it has to, because when we close that vein, we have closed that vein. Right. There's no more blood flow. It is amazing, and it happens because a lot of people say, "Well, gee, dude, am I growing new veins?" Yeah. And no, it's not really like that. You're not growing new veins. Getting back to collateral kind of things, the blood is finding other routes, and I tell people that are the venous system, the system of all the veins in our legs. It's kind of like a tree root. The trunk of the tree is the main thoroughfare, but the secondary and tertiary. I mean, there's all sorts of levels of tiny little veins that are there, and again, the blood just kind of finds its way in the right direction. Yeah,
and one of the things that we talked about before, once again, in the final comment about spider veins, is that spider veins are an elective procedure because it's cosmetic, it's aesthetic. It might give you better self-esteem, it might make you have more fun. Nobody's looking at your legs, but it's not. The insurance company is not waiting in line to send you a check, or Dr. Jewell a check for that. However, I do think that people always want to know this, and that is from the time I get diagnosed and what happens between the doctor and me and my insurance company to decide what gets paid for and what doesn't? That's really a great question, because the only thing that doesn't get paid for, I guess, is strictly spider vein cosmetic surgery.
Yeah, the only thing that's not paid for to some extent is cosmetic things in that spider veins.
Do you have to do some things as a patient before you get permission from your insurance company to have a procedure done?
Well, as a patient, no, because we do that for them. Okay. So, everything that we do has to be pre-authorized by the insurance company.
Of course, I guess.
So, but that's that's footwork that we take care of.
I'm guessing they're not standing in line saying, "You got any business for me today, doc?"
No, they are not.
So from what I understand, and I remember one of the first things that happened to me, everybody, was that it was going to be determined that I needed probably some major work done. But as a result of that, I had to do some things first. And that was, I guess, if you are in bad vascular condition, sometimes you better not do surgery right then, because you got to get, you know what I mean? Why do they make wear stockings and do all of these things before it was approved?
Well, the insurance companies have mandated a certain criteria that we have to meet in treating a patient before they will approve us to do the procedures and reimburse for them. And probably in general, what they want to see is that we have attempted to treat the patient conservatively. And
okay.
So
conservative means without surgery.
Yeah, without surgery or without procedures, and prove that the conservative therapy has not measured up.
Gotcha.
So is it sort of a futile kind of thing? Yeah, it is, because the conservative therapy for venous insufficiency, which is compression stockings, anti-inflammatory medication. And exercise and that kind of stuff. Is that going to cure that patient of their venous insufficiency? No, it never does. It's just it's a Band-Aid. I have found very, very few people who want to wear thigh-high compression stockings for the rest of their life.
Okay, now here's one for you, because I do know, and I, knock on wood, I was a little bit guilty of this myself. And I know that you can't fool a doctor. You can't fool your doctor. In other words, if you say, "Mike, were you wearing?" "Oh yeah, doc, I wore those things every day for a month." And you would sometimes have to say to the patient, "Well, maybe that's what you think, but that's not indicated by the way it looks. You're going to have to keep wearing these for so long." How can you tell if somebody is doing at home what they're supposed to do? It's pretty hard, I would imagine.
Yeah, well, you don't know, but usually what we like to see, if we're going to say, okay, this patient has come to us and they've already met the requirement of going through a course of conservative therapy. Usually, we like to see that the patient has been advised by another physician.
Gotcha.
For instance, like a lot of people will come in and say, "Well, yeah, I've had these compression stockings for 6 months. My primary care doctor said I should get them, and I've been wearing them." So we use that kind of stuff. So that's typically what we go on. Or, if we're convinced that the patient did, and usually we can tell, but even when we're directing the conservative therapy, am I convinced that everybody is wearing their stockings every day of the week? Well, no, because in a sense, it's a little impractical.
Okay, I've crossed that bridge. I used to make sure. Okay, I'm seeing Dr. Liff today, right? Where's my socks? And now it's, I do it because it needs to be done. But I also think, and this is really a sort of a wonderful thing about getting a little bit better, you become more proactive. And that's why we've talked about this in the past. And the only other question that I would have regarding the insurance company, because another guy mentioned a similar thing, and that is, what if something happens when you're traveling and you have an emergency? Obviously, that has to be covered by your insurance, doesn't it?
Yeah. Yeah, typically it is. Yeah, even if you have an insurance policy that mandates that you have your set of doctors that you have to go to. Yeah. If you're somewhere else and it's an emergency, and it's proven that it's an emergency, then that insurance company is held to covering you for that.
I know that everybody gets worried about it. We've talked about these, and there's been great analogies about people traveling long distance and then having something happen fatally when they're on a trip. Yeah. And I'm guessing that how is the rapid transfer of information from you here in Hawaii to where I am in New York, where I need some emergency help, and vice versa. Sometimes when somebody flies here and they come to your office because they get referred to your office right away, that you need to get those things. How easy is it to do that now?
Well, it's getting easier all the time. But we still haven't gotten to the point where everybody is connected electronically. Now if you're within the VA system, you are. And actually, the VA system was very early utilizing what we refer to now as the EMR, electronic medical record. And so it's kind of nice, the people who are within the VA system, they can be anywhere in the country, and the practitioners taking care of them can pull up their stuff on the VA system and see exactly what's been done and what what their medical problems are and all that sort of stuff.
And that's incredibly interesting. And by the way, I do a program, as you know, with Align with Veterans, Align Mortgage, and they steer people. They instead of calling it the Align Mortgage Show, it's just called the Align for Veterans Show. And the VA is a wonderful source now. Had some issues,
right?
But really have done stellar work to get that done
better.
with. And that's good because it's what we're talking about is a lot of our veterans that are older people who, guess what, vein issues.
Oh yeah. But even if we're not connected electronically, everybody has an EMR for the most part across the country, and so it's pretty easy to communicate with other doctors' offices and say, hey, can you fax us over your last 6 months worth of stuff on this?
But listen to Doc. You just said fax. Your people in your office are going to tell you, what are you talking about? Fax? Scan and email me that thing, and I get it. But I think that therein separates the men from the boys. It's not necessarily does every office you go to have to have brand new stuff that just came out of a box. But I think that what has not just fueled the success of Vein Clinics of Hawaii, but the patient level that you're able to handle is that you're not letting moss grow on any of that equipment, and that must mean a very big commitment to continually be having your ears to the ground and letting the manufacturers come and suggest this and suggest that. Because there was a guy when I had a procedure that was actually there, one of the vendors. That's not an uncommon thing, is it?
That happens periodically.
A lot of new stuff going on.
Yeah, it happens periodically, and one of the things that I found very interesting about vein care in treating people with vein disease is all the new technology that has come out over the last 15 years. I mean, it's been very, very interesting, and new things are coming out all the time. And do we try to keep up with all that? Oh yeah, absolutely, we have to. The manufacturers are a good point of contact to get info on the different devices and how they're recommending to use them. And it's fun. It's fun to have a number of different ways to treat things, and that way you can kind of fine tune how you are treating patients.
Yeah, and gang, one of the things you need to do is get in the pool, get in the rotation. You pick up your mouse and go look at veinclinicsofhawaii.com, and you will be surprised. Number one, it's a user-friendly website, but number two, there's some really, really good information on it. And I think that a lot of times that a lot of people listening to our show that are not patients, that won't be patients because they're not ill, but they have somebody else. Look at how many referrals you get from people who said, my son, my daughter was listening to the radio or seeing me in the store, and, I must have been in denial about this. What's going on here? What's it going to take to get me helped?
Yeah, we do hear that. Yeah, family, friends, etc. And and we often hear people who are patients, and usually it's while we're treating them. They say, "Oh, I told all my friends at work because they have the same kind of problems," or they'll say, "Well, yeah, I'm the first. I'm the guinea pig," and then my friends will come in.
And I am. That's what in my circle, and those people that have either come to see the doc or taken charge of their habits. I think that one thing, and the way we should lock it up, is now that we know that we have a disease and we're being treated, what are some things that you will suggest to somebody? Look, we can do everything, all of this stuff, but there are some things that you can do to avoid visiting me quite as often.
Right.
And maybe some of them you might briefly mention about diet or about other comorbidities or whatever, some of the things you can work on to increase your vascular health.
Yeah. Well, I think as related to venous disease, excuse me, weight is a big thing. Obesity kind of goes hand in hand with venous insufficiency. And people who lose weight can improve the situation. They can be improved by that.
It certainly helps your back and your hips and everything else.
Yeah. So in exercise, like we started out with, exercise is never a bad thing. It's always good.
Yeah, but look at how many people will tell you in the beginning of treatment was, I used to walk a lot and I can't walk anymore.
Mm-hmm.
And what's your goal? Not to climb the Eiffel Tower. My goal is just to walk to the supermarket and back. And isn't it amazing when somebody gets that goal that then they set the bar up even higher? And instead of having a downward spiral, they start spiraling upwards again.
Yeah.
That's what I love about everybody that listens to this show and calls you up.
Yeah. And the same sort of thing can be said about compression, compression stockings.
Yeah.
For those people, and basically I recommend everybody that we treat, I recommend that they stay in compression stockings to some extent, especially if they're working in an environment where they're on their feet all day long. But I think, like you, if people who have, chronic swelling and chronic problems with their legs, if they get in the habit of wearing compression stockings in a real dedicated sort of fashion, and they see the improvement that they can have, it gives them even more reason to be a little more consistent.
Okay, let's get into people that are somewhat reluctant. I'm all in, so I wear them from as early as I can in the morning to remember to put them on until the last thing I do at night is take them off. But I do know that some people would say, okay, I'm not going to do that, but I'll try it. Isn't it also true that there are different degrees of these things, that you don't have to get the leg in the tourniquet vice grip thing?
Right.
But by the same token, if you don't get enough compression, you're kind of kidding yourself too, right?
Yeah.
You got to find out, how do you determine what I need as far as compression?
Well, it's sort of standard. When we talk about medical grade compression, it's related to the amount of it's measured in pressure,
right?
And the lower one is. The lowest one that we use is 20 to 30 millimeters of mercury. Sometimes we use a higher one, 30 to 40. But 20 to 30 is kind of a good, moderate range.
Especially if you're going to wear them every day, like I do.
Right, exactly. And that's the fine line you have to walk. That we have to walk.
Sure.
We want people. The best is to wear thigh high compressions that are like 30 to 40 millimeters mercury.
Right.
That's going to give you the most compression and the best result. But are people going to wear that? No, they're not.
I've lost interest in your friendship when you mention that to me.
Yeah.
I'm kidding. I've done it and I will do it again when needed. But I want to tell you, if you're doing a little something, you might be tempted to do a little more something later.
Right.
And I'm experiencing that now. I'm now starting. I get a new, different kind today because I was concerned, Doc. You were showing me that I've been using these knee high, but they also have a foot opening.
Right.
And
Totally.
And so now I'm wearing the same thing. I just got them on today for the first time, which is the whole foot. And obviously it's a little bit better, and so isn't it amazing once somebody has done that, the next time they come to see you is they are in nowhere the state of deterioration than they were the last time. That's the bottom line.
And for us, that's our goal. We need to, initially encourage people and kind of, be consistently encourage them until they are able to recognize the benefits of some of the things that we're, recommending for them to do. And compression just makes such a huge difference. And so we try to do our best to inspire people to do that.
And that's why we should let our listeners know that that's the kind of question. There is no such thing as a dumb question here, by the way. But you need to get as close to the source as you can. And that's why I want you to go to veinclinicsofhawaii.com, because you'll see some pictures and you say, my legs are not that bad. Yeah, but they will be if you don't do something about it. That's why it's kind of neat to have those out there, don't you think?
Yeah,
and then there's another thing too, and that is from the time you take a look at somebody to develop a treatment plan depending on the severity of somebody's illness. How long does it take before you can get somebody into the queue to get surgery done? if they need it.
Yeah, well, pretty quickly if we have fulfilled that conservative therapy requirement. So we see somebody, and if we feel like if they've been treated before, or if their primary care doctor has had them in compression stockings, which we always like to see, but then it's a short period of time, and we get an ultrasound done, and then I kind of like to see the patient after the ultrasound so that we can go over exactly what it shows and what we think should be done, but then thereafter we can shortly get them into procedures and get them feeling better.
Yeah, and that's what I like about it, gang. It's so easy to do that. Thank you, Dr. Judith. We'll see you again next time. And if you need to know more about what we're doing here, you go to veinclinicsofhawaii.com, veinclinicsofhawaii.com, and let the professionals there show you the way to really get a good step forward. You put your best foot forward when you show up at Vein Clinics of Hawaii. See you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.